Hey, welcome back. Today we'll be covering a really important topic in physiology, and it's the cardiac muscle along with the action potentials. So, just basic rundown. Cardiac muscle is very similar to skeletal muscle, except that they have shorter sarcomeres and they are mononucleated, and that rather than skeletal muscle, it has something called T-tubules instead. And these T-tubules are at the Z disc, and they are basically channels that invaginate into the cardiac muscle in order to provide calcium. And they're grouped in two major systems, the atrial and the ventricular syncytium. And they have a slow contraction compared to skeletal muscle, low ATPase activity, so there's less relaxation involved, and most important of all, these can contract without any neuronal input, so your brain isn't telling your heart to constantly contract because this is a involuntary muscle. So the intercalated discs are made out of desmosomes to adhere the cells together physically, and gap junctions, which allow the conduction of the action potential and the ion flow, and allow the cardiac muscle all to work together as a syncytium. So remember when I said that they were divided into two, the atrial and the ventricular syncytium, and they work together all in sync. And there are no protoplasmic bridges present because there are gap junctions instead. So the syncytium, the ventricles will, or the atria will work together, and the ventricle will work together, but not. It's not in sync. Or what I should say is the atria work first. They contract a little bit before the ventricles, and then the ventricles will contract. But the atria will work together. They will contract at the same time, relatively. The right atria actually contracts like a couple milliseconds more, like not even milliseconds, far faster than that. But to identify the differences in the muscle tissue, it's going to be in an alpha isoform, which is a heavy chain that's found in the atria, and the beta isoforms, which are in the ventricles. So, and the alpha isoform chains will have higher ATPase activity, and the beta chains will have lower ATPase activity, which makes the contraction of the ventricles slower. Why is that important? Well, it's because the ventricles need to contract slower to eject all of the blood out. And there is a little bit less importance for the atrial blood to be ejected fully, but it's more important for the ventricles to eject all of its blood. So troponin is of course, it's a protein. If you recall from all the anatomy lectures and histology lectures, troponin is the protein that is attached to actin, or tropomyosin on the actin, and those, of course, get those like block the tropomyosin sites, and that's where the calcium attaches, and then the cross bridges can form. But more importantly, they are released when the muscle cells die. So it is a really important form for ischemic injury indicator. So if you have a myocardial infarction, your blood test will show higher levels of troponin, and they may not be detected in the serum for like 4 hours after onset. So you have to repeat them every 12 hours to make absolutely sure. So is this chart. This is the amounts of troponin released. So the first couple of days, there's going to be a huge spike in troponin that eventually taper off after 7 days. And the normal value is about like less than 0.4 nanograms per milliliter blood. So there's two different cells in the heart. They're cardiac cells, and those are, of course, the predominant cell. And they don't initiate the action potential. They will receive the action potential, and they will act on the action potential, but they don't initiate it. That is the job of the pacemaker cells. And the pacemaker cells is the entire conduction system. So those don't contract, however, they initiate the action potential. And the excitation coupling links the action potential and the myofibril contraction using those gap junctions. And this is a form to regulate calcium release. Okay, so calcium release is important because during contraction, let's first start with the potassium channels. Those are ungated, they're always open. And let's start from phase 0. So phase 0 is the depolarization of the cell. The sodium comes in, and then the resting potential of the cardiac cell is about like minus 90, minus 95 millivolts. Different in the muscle where it's like minus 80 or 85. So sodium comes in and it depols to almost like, positive 50. And then once those close, it's going to be the absolute refractory period, and that means no more impulses will force this to open. And then the L-type voltage-gated calcium channels also help to depolarize the action potential, so more positive ions come in, but they are slower, so they will kind of initiate that plateau. So first depolarization, and then potassium and chloride a little bit, but more importantly, chloride goes out, while calcium comes in. So that forces that creates the plateau phase. And the plateau phase is important because that calcium needs to come into the cell in order for the heart to contract. So if the fast cells channels fail to open, sodium will go through the voltage-gated calcium channels, and depolarization will still occur, albeit slower. So this is kind of like your backup. So inward rectifying voltage-gated potassium channels will close once the cell has reached a certain positive value, and then they will reopen during the repolarization phase. So once it kind of like gets like positive 50, those voltage-gated calcium channels will close, and then calcium comes in while potassium comes out, making that like even. And then the delayed rectifying potassium channels will open, and then they close slowly, but like they open and more potassium comes out, and then the cell is slowly starting to repolarize. So in the contraction cycle, phase 0 is going to be the rapid upstroke, and that is going to be your depolarization. And then phase 1 is going to be your initial repolarization. And phase 2 is going to be your plateau. Calcium in is equal to the amount of potassium going out. But remember, it's like a 2-to-1 ratio because calcium is 2 plus, potassium is only 1 plus. There's the L-type calcium channel that will open in the phase 2. And then there is a phenomenon called the calcium-induced calcium release. So from the L-type calcium channel, there's some calcium that comes in, and from there it attaches to something called the ryanodine receptor. And the ryanodine receptor will allow the calcium that is stored in the sarcoplasmic reticulum to come out into the intercellular fluid. So this depolarization from the L-type calcium channel is going to be calcium from the extracellular fluid from the initial plateau phase. Once the cell has contracted using all this extra calcium floating around, there is something called the transporter circa that will reuptake the calcium from the extracellular fluid, and then into the sarcoplasmic reticulum, saving it for the next contraction, and the rest of the free floating calcium will be pumped out into the tubules, and then from there it will go back into the extracellular fluid. Okay, so phase 3 is going to be your repolarization, just to say it again. So remember, first depolarization. This is going to be your initial repolarization, the slow repolarization. There's going to be the plateau, and then the rapid repolarization, and then the potassium will leave, and then phase 4 is going to be your transient hyperpolarization, where like a little bit too many potassiums leave, but then it will eventually go back to resting potential due to the leak channel. So remember when I said that there's always a couple potassium channels open, like they don't actually ever close, but they are slower. So there's going to be that transient hyperpolarization. So the voltage gated sodium in channel closed, and then the membrane fully repolarizes and return to resting potential. And I know that sounds like a lot of like repetition, but it's really important to get this stuff in your mind. So phase 0, depol. Phase 1, initial repol. That's when the sodium channels close, but the potassium channels open, so potassium can leave. Potassium continues leaving, and then the calcium channel close, and then potassium comes back in due to the leaky channels. And while all of this is occurring, like sodium is also still like entering. And that's how it's the cell is going back to resting potential, and the sodium comes in due to a exchanger. Okay, so during the refractory period, absolute refractory period is when all of the sodium channels are inactive. The effective refractory period is the longest period, and it can still be initiated. Excuse me. Action potential can still be initiated because some of the sodium channels are starting to be recovered towards the end. Relative, some of them are still active. Action potential is possible, but the stimulus must be high or summated. Well, it's a bit of a contradiction because heart muscle cannot be summated. Like action potential in the heart cannot be summated. So this statement doesn't really apply, but it's important to know that in skeletal muscle this is possible, but in heart cardiac muscle it is not. So the boards like to test on that kind of stuff. Supernormal period is kind of during the hyperpolarization, where the cell is hyper-excitable. And so less inward current is recovered because most of the sodium has been recovered and the membrane is closer to threshold. Okay, so there is no tetanus in the heart because of the long refractory period, so there is no summation. The tetany will lead to death because the heart would not be able to contract. So what's interesting and how like all of this plays like in the contraction cycle is that this is all dependent on concentration of ions. There is no neuronal input besides some minor caveats like vagus nerve stimulation during like a fight or flight situation, but in general this is all dependent on just like gradients and concentration. So once the heart has reached like minus 90, 95 millivolts due to the repolarization of the cell, it will instantly depolarize, reaches a certain threshold, starts to repolarize, and then reaches another threshold. And then it will go through the plateau, and then of course the rapid repolarization, hyperpolarization, and then it will occur all over again. It's important to know that this will be kind of like perpetual motion. This will always occur, because once this stops, once these like systems stop, like you die. The interesting thing is, like, like, why do people pass away peacefully from, like, heart failure and stuff? Like, wouldn't this just kind of keep going? Well, no, because as you age, there's less like, there's going to be damage to the cardiomyocytes, of course. There's going to be less receptors, and then there's going to be slight failing of the heart's ability to reach the appropriate levels in order for the heart cells to, like, depolarize, along with, like, the weakening of the muscle fibers itself. Okay, so this chart is different from the other charts because this is going to be only for the pacemaker. So, like, it's really important to know the difference between the two. The other ones were the contractile cells. This is going to be the action potential cells. So, as you can see, this one doesn't have a phase 1 or 2. Instead, it just has your upstroke. So it has your depolarization, your repolarization, and then the hyperpolarization up to, like, threshold phase. So in phase 0, the voltage-gated channels are going to be permanently inactivated because the resting membrane potential is less negative. So compared to the heart, the cardiomyocytes, the contractile cells, that's minus, like, 90. This is going to be minus 60. It's going to be, like, once it's shut off, it's shut off. There's no like, you can't sum. This is the important function. Like, you can't sum these potentials. So same deal, phase 3, inactivation of the calcium 2 channels, and then potassium leaves. In the meantime, sodium comes in. It's a lot more prolonged in the pacemaker cells compared to the contractile cells, because there needs to be a slow diastolic depolarization. And then, like I said before, there's going to be the spontaneous depolarization the minute it hits a certain threshold. And it's prolonged because the heart needs some time to contract or, like, relax to fill. So the slope of the phase 4, this one, is going to determine the heart rate, of course, because if this slope is sharper, the threshold potential is reached faster, and then another depolarization can happen sooner. Okay, so the autorhythmicity is unique to only the cardiac muscle. Like, only the cardiac muscle kind of works on the concentration of the ions. Let's see, the amplitude is lower because of the low amounts of calcium, of course, because they have two sources of calcium. So why does the cardiomyocyte need to store so much, right? And moreover, the duration is longer, so you don't want to contract very hard, because when you contract hard, you contract quickly. So you want to contract slower to eject all of the blood. It's pretty efficient too. Less ATP is used for contraction, so the heart doesn't constantly need to be supplied with ATP. Rather, all that ATP can go to the brain. And the contraction lasts as long as the action potential. So long action potential, long contraction. Okay, so let's compare the contractile cells to the pacemaker cells. The SA node is going to determine the action potential of all of the pacemaker cells, unless something has damaged that SA node. So in the atrium and the ventricle, the action potential will propagate into the contractile cells. And in the ventricle and atrium, they have all the phases and a plateau, so they will have these. While in the sinoatrial nodes, or the atrioventricular nodes, there's no plateaus. Repolarization in the sinoatrial node is going to be faster than the ventricular nodes. Why is that? Well, it's because there needs to be that pause in the ventricular node. Right, so let's go through the excitation contraction. I already said this, but calcium comes in from the extracellular fluid into the intracellular fluid. The right antigen receptor occurs. The calcium spark would be the signal for the calcium-induced calcium release. And then, of course, calcium binds to troponin, cross-bridge is moved, or tropomyosin is moved, cross-bridge occurs. Circa reuptakes it, troponin is released. The sodium exchanger will pump 3 sodiums in during the repolarization phase and 1 calcium out. So that allows the contraction to end. So once the calcium has run out, contraction ends. Cell is now repolarized at threshold, ready to fire again. The sodium potassium ATPase transporter will maintain the chemical gradient of potassium and sodium. So this will occur within the contractile cell. So this doesn't have anything to do with the action potential. That's important to note. Okay, so the Frank-Starling mechanism is an important mechanism to know because this is the ability of the heart to adapt to increasing volumes of inflowing blood. So more blood in, there's going to be a greater stretch of the ventricles, and then that leads to greater stroke volume. Why? Because now there's more blood in the ventricles, it can eject more. So with more blood volume to eject, there's going to be a greater contraction, and then a greater ejection fraction into the pulmonary trunk, and that increases pulmonic pressure. This is important because this it forces more blood into the lungs and thus more like oxygen in the body. And there is also greater ejection fraction into the aorta, and that also propagates more blood flowing through the body. So the force of contraction depends on the overlap of thick and thin filaments, and there's okay, so imagine the heads of these overlying the actin. There is going to be 2 rows of actin, which this of course does not show, very disappointing, but there's going to be 2 bands of actin, and the let's say there's another band on top, and this yellow band will kind of block the other band's sites, and the myosin heads are going to be very particular. So if the heart is stretched, more of the myosin heads are going to be able to reach around, to the other strand of actin, and then that will allow the harder contraction because there's more, heads binding, there's more cross-bridge cycling, and besides that, there is something that binds the actin and myosin to the Z disc, and that's called titin. Titin is just think of it like a coil or a spring. So when these are stretched further, of course, the coil is going to snap back harder. So there's going to be a harder contraction. So this only works to a certain extent. If the sarcomeres are overstretched, there is not going to be any overlap, and then the quality of contraction is going to be decreased, and then you hear it in a murmur when the ventricle walls are hypertrophied. So as you say, calcium comes from 2 different sources, from the sarcoplasmic reticular inside the cell, and from the outside due to the depolarization. Okay, important. The anti-arrhythmic drugs, there are 4 classes that we need to know right now. The first is class 1 is going to be the sodium channel blockers. That is going to affect the depolarization, so it's going to affect phase 0. And then there is going to be so these really affect the contractile cells due to the contraction, due to the depolarization, and allowing the calcium, it regulates the calcium efflux. For class 2, there's going to be, it's very well known, it's the beta blockers, 2 beta. Just how I remember it. So beta blockers will inhibit the catecholamines, and that inhibits phase 4. So down here during the polarization into the action, or into the threshold level, and that really affects the SA and AV nodes, so that will control the heart rate. Class 3 is going to be the potassium channel blockers, and that will prolong the repolarization phase, and that will also control the heart rate. And then class 4 is going to be your calcium channel blocker, and that inhibits the action potential in the SA and AV nodes, like just by purely controlling the force of contraction and just not allowing it's not going to allow the calcium, sorry, I was thinking there, the calcium to exit. So of course there's no calcium, less contraction. Okay, so calcium channel blockers is going to be like a double whammy. It's anti-arrhythmic and anti-hypertension. So it's going to control the heart rate, and it's going to control the blood pressure, heart rate first. Okay, so there's not going to be any calcium coming out, and that's going to affect it's going to affect the contractile ability of the heart. So it's going to prolong the phase 0. It's going to prolong the depolarization, allowing like a slower contraction. So that's how it controls the heart rate. Antihypertension is because it's going to squeeze less blood out with a slow contraction. So it's going to bring the blood pressure down. And it also relaxes smooth muscle. And the cardiac effect is that, like I said, it's going to detract the contractility and slow the velocity, and by decreasing the firing rate and the AV node conduction. And there are two different drugs. There's the dihydropyridine, and that works only on the vessels, while the non-dihydropyridine is going to be specific to the heart. Okay, so that's it for now. Thank you for your attention, and good luck studying. Know these things by heart. This is an important topic for physiology, and then on to pathology.